Welcome back. And so our next speaker is Erica on the other pigments illuminating the spectrum of macular pigment in albinism. And a fun fact, she has a new puppy who takes care of it the whole day.
Thank you so much. I know most people here know me, and I'm excited to tell you a little bit about some preliminary data I have on this new project. Though I've been interested in albinism for quite some time, we are looking at macular pigment. But of course, I think it would be a little mean to tell you that I got a new puppy without showing you some photos. So here you are for your viewing pleasure. This is Rudy, weighing in at a hefty 2.5 pounds right about now, has been ruling the house around my house these days. But on to the topic at hand, which is albinism. This is a genetic condition that leads to reduced or absent melanin, and it impacts the development of the visual system pretty significantly. It tends to cause foveal hypoplasia, increased decussation of the optic nerves at the chiasm, as well as kind of some unusual organization of visual space in the visual cortex. If we focus especially on foveal hypoplasia, we often find that there is a wide spectrum of phenotypes. So some individuals are affected more severely than others. And so you can see that in a less severe phenotype, this person has almost a fully developed fovea with just some residual interretinal layers at the foveal pit, whereas this individual really has no evidence of any foveal specialization at all. You know, that formation of a pit, the elongation of outer segments, and thickening of the outer nuclear layer. So it's not an all or nothing phenotype. Clinically, when these patients come in, they tend to have reduced visual acuity, nystagmus, changes in their depth perception, as well as photophobia. But really the piece that matters most to patients is that visual acuity, because that's often what dictates what their lifestyle might be going forward. We know that of the different changes in the visual system in albinism, that foveal hypoplasia is the one that is most closely correlated with visual acuity. So people who have more severe foveal hypoplasia tend to have worse acuity, less severe foveal hypoplasia, better acuity. But this relationship isn't perfect. You can see in this graph on the slide over here that there's a lot of overlap between different grades of foveal hypoplasia, which means there's a lot of factors that we don't yet know about that are contributing to determining visual acuity in this population. So one area that we are interested in looking at is macular pigment. This is a completely different type of pigment, so hence the other pigment, that is completely unrelated to melanin. And what I'm referring to here is carotenoids. These are yellow pigments that we actually get from our diet. We don't make them, but they're found in high concentrations in the macula, in the normal retina. We are all familiar with these autofluorescence images where there's kind of this blunting of that autofluorescence where it's darker right at the fovea, and that is because of absorption by the macular pigments. And you can even measure that absorbance across the image to see how much approximate macular pigment someone might have. We now have some more quantitative methods of measuring macular pigment that I'm going to go into more detail about in a minute, but when we plot macular pigment as a function of distance from the fovea, you can see in this lower plot that normally there's a very high concentration of macular pigment right at the fovea, and then it falls precipitously as you get further away. In someone who is vitamin A deficient, which is shown in that left plot, you can see there's a much lower level of macular pigment. Whereas in someone who is eating lots of fruits and vegetables, maybe lots of dietary supplements, they're going to have higher levels, as in that plot on the right. So what we do know is that when we give people dietary supplementation of carotenoids, that it reduces their risk of age-related macular degeneration. This is part of the rationale for the AREDS vitamins. And it also reduces visual impairment from glare. So there have been some questions about what the role of macular pigment might be in albinism, and whether this is different, whether this is contributing to visual acuity in this population. People have tried looking at this in the past, and the evidence is a little bit conflicting. Historically, when people have looked at histology, they've said, no, there's no macular pigment in albinism. We really don't see it in our samples. And even when people have looked at some of those fundus autofluorescence images, whereas in a normal individual, which is the plot on the left, you have that drop in autofluorescence signal right at the fovea. In a lot of individuals with albinism, as you see in the plot on the right, you don't have that drop, kind of implying that there's no macular pigment. Since we now have these more quantitative methods of measuring macular pigment, some people have started to look at this and said, you know, actually, in some of these individuals, there might actually be a little bit of macular pigment, not a normal amount, but a little bit. But it's still unclear exactly what that means for their vision. And all of these studies are limited by small sample sizes. So even in this more recent study, there's only about 4 or 5 patients in this cohort. And so it's really unclear how this varies across the spectrum of phenotypes, and again, how it might affect vision. So the goal of this project is to ask 2 questions. One, just is there macular pigment in albinism? And we can kind of go into some of the nuances there. And secondly, does this affect visual acuity? So we are in preliminary stages of gathering some more data. One of the ways we can measure macular pigment, as I alluded to earlier, is macular pigment optical density, or MPOD. This is a specific way of autofluorescence imaging where it's actually dual wavelength. So it's measuring both green and blue wavelength autofluorescence signals and taking the difference to quantitatively calculate the macular pigment. Those are the plots that I was showing you earlier. And this is actually just an additional module on the Spectralis OCT device. So this is something we have here at the Moran and is reasonably accessible to our patient population. One of the other imaging modalities that we're exploring is fluorescence lifetime imaging ophthalmoscopy, or FLIO. This is also a specific type of autofluorescence imaging, where instead of just measuring a signal or the amount of autofluorescence, it's also measuring how long that fluorescence signal lasts. And we know that when we look at this with 2 different wavelengths, that in normal individuals, there's a peak right at the fovea where the fluorescence lifetimes are much shorter. And one of the previous residents in the program, Lydia, has previously looked at these shorter lifetimes at the fovea and correlated it to the MPOD measurements of macular pigment and shown that there's a really good spatial correlation between those shorter lifetimes and the peak of macular pigment. And so we've kind of concluded that these shorter lifetimes probably correspond to macular pigment. And then in albinism, what we're hoping to do is measure macular pigment in both of these ways and then correlate it with foveal anatomy using high-resolution OCT. So far, we have enrolled 5 patients with albinism, and so these are just some characteristics of these patients here. We have 2 adults and 3 kids. We're also doing genetic testing on all of these patients just to help us with making sure we have the right diagnosis and characterizing that contribution as well. And most of these patients, as you'll see here, have more mild foveal hypoplasia. And that's also demonstrated in their OCTs. So I'm showing you the left eye from all 5 of these patients here. The OCT is on the left, and on the right is their MPOD measurement. So again, that's showing you macular pigment level as a function of distance from the fovea. And in one patient, we weren't able to get MPOD measurements, most likely due to nystagmus. That does influence our ability to get good imaging, which I'll talk about more in a sec. But what's interesting in looking at these patients is, first of all, that 3 out of the 4 have very clear increased macular pigment right at the fovea that you can see on that far left side of these plots. It's not quite in the normal range of what you would expect in someone without albinism, but they do have some accumulation of macular pigment. Even that participant A4 has a little bit of increase of macular pigment at the center relative to the periphery. The other thing that might be just qualitatively apparent here is that the individuals that have a more specialized fovea, so a fovea that looks more like a normal foveal pit, particularly this patient A2 or A5, they tend to have a higher level of macular pigment right at the fovea than, for example, A4, who has a less developed fovea and has a lower peak macular pigment. When we compare the peak macular pigment to the foveal thickness or the retinal thickness at the fovea, which we're kind of just using as a correlate of foveal specialization, there is a very rough correlation here. Again, it's a very small sample size, so it's not a strong correlation yet, but I think this does show promise that as we collect more data and enroll more patients, it'll be exciting to see whether this relationship bears out. We've also started to compare the MPOD data to FLIO data. And this is an interesting thing to look at, particularly if we compare these two patients who both had reasonably high levels of macular pigment right at the fovea based on their MPOD measurements. And in the patient on the left, in A5, when we look at their FLIO images, they do have a very subtle peak at the fovea of shorter fluorescence lifetimes, which could correspond to that increased macular pigment. In A2, however, when we processed the data the exact same way, there really wasn't a lot of variation in the FLIO signal across the fovea. And there's a couple reasons why this could be. Part of it is likely just the way that we're processing our data. We haven't looked at the FLIO data in this population before. It's very likely that we might have to make some tweaks for this population, particularly because there's still some questions about the exact source of the FLIO signal. While we do think that these shorter lifetimes at the center are coming primarily from macular pigment, there's been a lot of questions about how much of the FLIO signal actually comes from melanin. And so in this population that has reduced or absent melanin, that likely affects the FLIO signal and is going to be really interesting to see as we're able to look more closely at this data in the future. So thus far, we are seeing that based on this very small sample size so far, macular pigment does appear to correlate with the level of foveal specialization. So the less severe the foveal hypoplasia, the more macular pigment these patients seem to have. One thing to keep in mind anytime we're doing an imaging study in this population is that a lot of our findings are likely influenced by sampling bias. And that goes back to what I mentioned before about how nystagmus often affects our ability to collect really good images and get reliable data. And what that means is that the patients that get included in these studies tend to be the ones who have less nystagmus, which are less severe phenotypes. And so that means it's a little harder for us to get a good look at the individuals who have more severe phenotypes or less developed foveas. And so that's just something that we'll keep in mind as we are drawing conclusions generally for the population. And as I mentioned, we're looking at the FLIO data. We're not entirely sure how this is going to bear out in the future, but I think it's going to be really informative, not just for albinism, but also to help us understand more about FLIO itself, because this is a new imaging modality that we're still working on developing clinical applications for, and I think this will be helpful to show us how much melanin may or may not affect that signal, even in other patient populations. So in the future, we plan to recruit more patients with albinism. Just to show differences between albinism and normal pigmentation, we don't need too many patients, but we will eventually recruit some of those patients who don't have albinism so that we can compare our population to age and sex-matched controls who are normally pigmented. And then eventually we'll correlate the macular pigment, as I mentioned, with visual acuity to see if there's any correlation there. One thing that we're also planning to look at is Henle fiber layer distribution. The Henle fiber layer is one of the layers in the retina where we think macular pigment is normally found at high concentrations. And we already know that we can measure Henle fiber layer thickness in both individuals with albinism and in normal controls. And we do know that the distribution of that Henle fiber layer is different in albinism than in normally pigmented individuals. And so this, I think, will probably play a role in helping us understand how macular pigment is sequestered at the fovea and how that change in foveal structure affects what we're finding with macular pigment. And ultimately, we'll also compare to serum levels of carotenoids, because again, in people without albinism, we know that there's a good correlation between macular levels of carotenoids and serum levels, but that same relationship might not hold true for people with albinism. So with that, I want to acknowledge my research mentor, Dr. Bernstein, as well as other members of the Bernstein Lab and our clinical studies teams that have all been really instrumental in recruiting patients, collecting data, processing data. Thank all the clinical faculty that have allowed me to recruit patients from your clinics, as well as my PhD advisor, Joe Carroll, who got me excited on studying albinism in the first place, as well as all of our patient participants who've made this research possible. And then, of course, I would be remiss not to mention Rudy. This is a picture of him helping me make my slides for this talk. And these are my references, and I'm happy to take any questions.
Moving on to our PGY2 group, Nadim Azar is going to talk to us about machine learning and confocal microscopy. Interesting facts about this young fella. One is he is still a partier, and that was brought up last year. And the second thing I didn't know is he's a music producer. So we have a multi-talented group of residents here.
Hi, everyone. So I actually started as a joke. It was in the resident open house, and they asked us about fun facts, and I was caught under pressure, and I said I'd like to party, and it became an inside joke with the residents. So now I have to fulfill the prophecy. But very happy to be presenting today. Part of my slide is cut, but talking about innovations in corneal imaging, mainly focusing on confocal microscopy and machine learning applications. So this is a gross layout of what we'll be discussing today, starting with an introduction, some methods, the results, and discussion. I have no financial disclosures to declare. So one of the most powerful tools we have in corneal imaging is confocal microscopy. It allows us to see nerves, it allows us to see immune cells, neuromas, without needing to go for invasive biopsies in the cornea. And it helps us see the layers of the cornea, particularly the subbasal nerve plexus, or the SNP, which is relevant to this discussion. The subbasal nerve plexus contains these nerves, immune cells, and neuromas, and can be very helpful in diagnosis and treatment of different ocular surface diseases, including dry eye, neurotrophic keratitis, neuropathic pain. The current challenge with segmenting or looking at confocal microscopy images is that it's really time-consuming and subject to inter-observer variability. So we need a more standardized way of looking at these layers. So the aim of this project was to develop and validate an AI, or automated deep learning algorithm, that would be able to segment automatically confocal microscopy images after manual segmentations by trained readers. So confocal microscopy, how it works, it's a direct contact machine. We have two different ways of segmenting, either looking at sequence images, which are focused on one plane, or volume imaging that goes through about 100 microns, which is 20% of the cornea, which means that if we start at the top, we basically get about 20% of the cornea through volume scans. The subbasal nerve plexus is between the basal epithelium and Bowman's layer, about 50 to 80 microns. That's the relevant one to this discussion. And these are some pictures of what you can see on confocal microscopy for the different layers. And this is relevant because I'll be showing different images throughout the presentation. So on the left, you can see images of the epithelium, in the middle, the subbasal nerve plexus, and then the anterior stroma, which is also visualized within this 100 micron scan. So this project was actually started when I was doing my postdoc back at Duke University, just before starting here. I continued partly here, but we gathered patients, controls, and ocular surface disease patients from the Duke Eye Center. They were imaged with the Heidelberg retina tomograph, but we added the corneal Rostock module to it to be able to visualize the cornea. Did volume imaging, as discussed previously. And then working with the biomedical engineering team, we developed two different data sets. One of them, which was a neural network called AARNet, the purpose of was to remove artifacts. Taking pictures, we don't really have clean pictures on confocal microscopy. Being a direct corneal touch machine, you get a lot of applanation artifacts. So we want to train a machine to be able to localize the area of interest. And then the second neural network was the one focused on segmenting nerves, immune cells, and neuromas. We used 470 images on 117 eyes for the first one, 207 images for 69 eyes on the second one. And then more importantly, there was no overlap between training and testing sets, which means that the machine was able to generalize on data rather than memorize data previously, and this would ultimately give us better results. So what are the structures that I've been talking about? The nerves, the neuromas, and the immune cells. On the left, you can see an image of the subbasal nerve plexus, highlighted in colors on the right side. Nerves were defined as thin, continuous, hyper-reflective linear structures, as shown in red here. Neuromas were asymmetric focal thickening or swelling along the nerve fibers. They were documented by initially by Dr. Chinnery et al. They look at as bright, irregular enlargements, sometimes confounded with immune cells, but they happen on the nerves, so they're part of the nerves. And the immune cells, which were subcategorized into different types, some of them are really round, some are branched, some are concentric, and they are shown in green here. So how we did this was initially had trained human graders defined as ground truth. They did a lot of research about this. They were experts and knew how to label these on manual segmentations using a MATLAB tool that was designed by the biomedical engineering team, which helped us basically just retrace and segment these nerves, find the immune cells, find the neuromas, and just label them in colors. It was a tedious, long process, but was necessary for training the algorithm. The goal was to get this ground truth data set so that the AI can be trained and have consistency among different graders. So many of us don't know a lot about AI, but grossly, the first part was, it was divided into two major steps. The first part is trying to label that area. So we want to give the AI images of the epithelium, the stroma, and the subbasal nerve plexus, and be able to train it to detect that subbasal nerve plexus alone and segment it alone. It uses what we call a generative adversarial network, or a GAN. The purpose of it is to fool itself. So it's like two trainees teaching each other. So it creates something and tests the other part of the network and then goes back, and it's a constant loop of training. The data set, like I discussed previously, those are the numbers. So focusing a little bit more on the first part, which is trying to detect the subbasal nerve plexus and separating it from the epithelium and the stroma. This is a representation of the isolation of the plane. These are some images on the left with applanation artifacts. So we don't get clean images. Oh, we can't see the arrow. But the subbasal nerve plexus has some artifacts or applanation artifacts, particularly in the periphery of the pictures. Some of them are stroma-related, some of them are epithelium-related, and we want the AI to be able to segment these areas separately so that we can have good quantification of these measures in the future. So it labeled the SNP in red, and then the stroma in blue, and the epithelium in green after it was trained. And then part of this was to fine-tune and optimize the segmentation of this area. And this was interesting because we used another network that is called a generator-discriminator function. The purpose of it is that the neural network is able to generate fake or artificial images that resemble the images that were taken. And the goal of the network is to try to discriminate between these images, and the more it is able to discriminate between them, the better the network becomes. So at the top row, you can see real images, and then the bottom row is completely generated AI images that were used to train this algorithm to become better and more proficient at segmentation. And this is the second part, which is actually labeling what we see. This is what we're looking for. We trained the AI model to segment based on the reader segmentation, and then ultimately did a 21-fold cross-validation, which is splitting the entire data set into 21 groups, training on 20, and then testing on one at a time and doing all the combinations. That made the AI much more powerful. Those are the images on the left. The first reader segmentation is the second column. Readers 2 and 3 also done to compare human to human and human to AI results ultimately. And the last row is the complete from scratch generation from the AI segmentation. And this is a schematic segmentation summary. So we start with images, and then we can give it images that have applanation artifacts. And as you can see, there's a lot of comparison between the automatic segmentation and the reader's segmentation. Looking at the last two columns, they are both able to remove the applanation areas and segment the SNP adequately. We also tried to look at some clinical metrics, measuring nerve and immune metrics from the segmentation. So the confocal microscopy scan is 400 by 400 microns, which gives it a total area of 160,000 microns square. We looked at nerve density within this area, average nerve thickness, nerve segment tortuosity, looking at vectors and seeing how much they're tortuous, junction points to see how much there's branching of these nerves, and then the number of neuromas and number of immune cell density. And then we did an interclass correlation coefficient to be able to compare. So these are the results. First of all, for the performance metrics, we use something called the dissimilarity coefficient, or the DICE score. It looks at the overlap between the images. So we take the picture, the segmentation done by the reader and the segmentation done by the AI and look at how much overlap there is between them. A score of 1 means a perfect correlation, and 0 means 0 overlap. Looking at the DSEs, they're all above 0.7 almost, particularly for background and nerve, so which shows that the AI was really capable to segment very similarly to an expert human grader. After that, we tried to see if we could compare it to human variability. So we compared the performance of the AI versus the ground truth or reader 1, and then we got 2 other readers to segment and then compare it to the reader 1 as well. And we saw that there was a lot of similarities between them. Also looking at the numbers, all above 0.7, particularly for background, and a lot of good comparison between the readers, which shows that it can be present within a variable range of human expert graders. And finally, looking at these metrics that I discussed previously, these are the absolute numbers of the metrics defined by the AI, but also by the ground truth, which is reader 1. And for this, we needed to use an interclass correlation coefficient. Usually we define 0.9 as excellent and between 0.75 and 0.9 as good. So it was good to excellent in most of the categories, which shows that it does have a clinical reliability and applicability in the future if we were to plan on using it for particular diseases and metrics. So the strength of this neural network generation is that it was able to achieve very comparative measures to humans, but also it's the first of its kind to be able to remove these applanation artifacts and get completely clean images based on whatever images we can get in clinic. It was also the first model, to our knowledge, to segment neuromas and immune cells. The ones in literature mainly segment nerves. And then it was released open source so that other people can build on that in the future if they want to use it. The limitations is that it relies a lot on good image quality, although it can remove the applanations, but we still need inherent good image quality to be able to train the network well. And then we defined the ground truth as the truth defined by one of the readers. And there's always some judgment or inherent human variability when we're using that, so that's one of the limitations. It does have limited rare feature detection, so we train it on controls, but also some ocular surface diseases, but there are a lot of rare findings that we did not train the algorithm on. I'll talk about some of them in the next slide, but rare nerve patterns, atypical immune cells. And then small patch size. Sometimes we're looking at smaller patch sizes, and then we can't get the big picture, so we need more of a mosaic picture of the confocal microscope to be able to train the AI to see bigger things that it could possibly miss on smaller patches. These are some of the segmentation errors I was talking about. So these are the raw images on the left, circled in yellow are the parts I want to point to. In A1, the first part is it's an anterior basement membrane dystrophy. It was labeled by the AI or the neural network as nerves and neuromas in the third column. Looking at the last one, it was not labeled by the ground truth or the reader because we knew that it was an anterior basement membrane dystrophy. And then part of the applanation removal sometimes is not super precise. There are parts of the stroma here that was labeled as immune cells and neuromas. And finally, some of these nerves, some of the immune cells can be really branching or dendritic, and they look a lot like nerves. So the AI labeled them as nerves while they were actually immune cells. Future directions, some thoughts to expand validation across broader corneal diseases. We include more in our sample, and then we can test it on broader corneal diseases to make sure that it is applicable. Improving the robustness, getting more numbers to improve the image artifact removal. Developing real-time clinical analysis tools like the ones I used and trying to apply them to literature and whatever we can find in clinic. Expanding biomarkers, we were looking mainly at the nerves, immune cells, but we can look more than density, tortuosity, and find other metrics. And finally, we can predict disease progression and treatment responses. Things that I can think about like neurotrophic keratitis, where we're looking at nerve regeneration, trying some medications like oxervate or Sanagermin, and trying to see growth sprout of the nerves. We can actually quantify those if we have a standardized way of measuring the nerves and seeing how they expand over time with treatments and monitoring disease progression using this technology. I'd like to acknowledge the team at Duke, mainly the clinical team, but also the biomedical engineering, and my mentor, who I worked with the postdoc with, Dr. Victor Perez. Thank you very much.
Our next speaker is Aman, and she will talk about small eyes, big problems, unpacking early onset high myopia. And your fun, but maybe a little bit concerning fact is that your PCP told you that she never saw so low vitamin D levels. So I think we need to give you somewhat free time to be outside.
Yeah, you never want to be a first for your doctor, but thankfully my vitamin D levels are now within normal limits, and I'll be at a lower risk for osteoporosis moving forward, hopefully. So small eyes, big problems, unpacking, early onset, high myopia. Really excited to be here. Thank you so much for giving me the opportunity to talk about this. This is not necessarily a results talk yet. I'm going to be presenting a literature deep dive and laying a groundwork for the retrospective study that we are in the process of executing this year. Basically, my goal is to connect the dots between what we already know and what we should investigate further regarding early onset high myopia, which in my opinion is often overlooked despite having pretty big implications. So this is going to be our roadmap for today. We're going to talk about clinically focused literature review, why this topic matters, and then the study framework we'll be launching this academic year. So for our background, high myopia in preschoolers isn't just a numbers game. It could potentially be a red flag. I reviewed key literature across 6 domains, mainly definition, prevalence, natural history, anatomy, associations, and clinical implications. And the goal was basically to extract insights that are actionable for clinicians. So why should we care about early onset high myopia? We're talking about less than or equal to -6 diopters before age 6, which is fairly rare, but it's not rare enough that we should dismiss it. It seems seemingly seldom, it's rarely isolated too. So this refractive error might be the tip of the iceberg for something bigger like syndromic diseases, underlying systemic conditions, and other ocular conditions as well. And moving forward to a hypothetical case here, you have a 4-year-old that walks into your clinic with -7 diopters in both eyes, no syndromic features, no family history. The only thing in the EMR that they're diagnosed with was certified cutie. But do you refract them? Do you just say, I'm going to see you next year? Do you dig deeper? Do you get more biometric data potentially? So this presentation is my attempt to answer the question, what do we actually know about these kids? So this isn't just the garden variety myopia that we're used to seeing. These kids have not even hit kindergarten yet, and their myopia is pretty severe. It's earlier, tends to be more aggressive, and often linked to something bigger. So we can potentially think of it as a diagnostic clue, not just a refractive label. So moving forward to its natural history, how rare is it? Turns out around less than 1% of kids under 6 have high myopia. But that 1%, they're disproportionately at risk for amblyopia, strabismus, syndromic diseases. And based on some of the literature I looked at done in the United States, mainly in California, as well as in Maryland, particularly Baltimore, they've stated that African American and Hispanic children have a higher rate of early onset myopia. So I kind of wanted to touch upon that because, we know environmental factors, systemic health risks, potentially like prematurity, and importantly, disparities to access and early eye care likely all contribute. However, a subtle but critical point is that if cycloplegia isn't used rigorously, particularly in young children who have pretty amazing ability to accommodate and also have darker irises, we might mistakenly label them as having high myopia, where they might actually be hyperopic or even emmetropic. So this could potentially either inflate the numbers or delay accurate diagnoses and intervention. So as we tackle early onset high myopia disparities, it means that both earlier access to care and also ensuring high quality standardized refraction practices. So regarding progression, I think one of the more frustrating things I found when doing the literature review, or potentially interesting, early onset high myopia is incredibly unpredictable. Some kids with -10 diopters tend to be very stable. Others with spherical equivalent of -6 to 8 tend to progress before even they hit grade school. But it turns out that most exhibit stability. The quoted number is around 60%. And some of the literature suggests that red flags that we need to look out for are being older within the preschool range, being female, and having a longer axial length. And as we look beyond refraction, this is one of the more interesting findings that I came across. Axial length can increase even when refractive error plateaus. So if we're just looking at spherical equivalent, we might miss silent progression. And they also found that axial length to corneal radius ratio could potentially be a predictor of higher degree of myopia when compared to seeing axial length alone. All right, so moving forward to associated conditions. This says looking beyond the eye, but still looking at the eye. Regarding the ocular associations, we see strabismus a lot with these kids, especially exotropia, when in fact a lot of younger kids tend to have more esotropia during as they're super young, but in these particular patient populations, we tend to see exotropia more. Cataracts, also something that's fairly common, tends to be congenital. There's research that says removing them early on might actually reduce progression. We have glaucoma risk with larger cups, high IOP, as well as longer axial length. Moving forward to systemic associations, this was a study, the table on the right, was a study done in 2001, and I believe they looked about 120 children less than 6 years old. And a majority of them had systemic associations, as stated over here, and around 20 to 30% had ocular associations, and not a lot of these kids didn't have any sort of associations with either condition. So, and a lot of these kids, early onset high myopia might be your first and only visible clue to something bigger. So it's really important that we pay attention to it. So for clinical implications, what should we do in clinic? For one, screening early and often in high-risk kids is really important. We can potentially track more than just refraction, maybe including biometric data annually could be helpful. I think, involving genetics as well as pediatrics, if we see some red flags, is a good option. There's also one study that showed that low-dose atropine can potentially blunt progression, though this needs more research in this younger cohort. All right, so moving forward to the study framework, my hypothesis is basically fairly simple. It means that preschoolers with myopia linked to systemic as well as ocular disease could potentially show different progression pattern and might be greater in magnitude. So want to test this with a retrospective database. And just like Ashley, we'll hopefully be using the source database. This is a large EMR-derived cohort. Going to be casting a pretty wide net, but applying a fairly strict inclusion criteria. basically spherical equivalent of less than or equal to half diopters before age 6. And it would be really helpful for these kids to also have pretty good follow-up as well as biometric data. And the idea is to get, both depth and breadth without sacrificing data quality. So for our variables, primary outcome is going to be refractive error over time, but the magic hopefully is in the secondary data where we're looking at axial length, corneal curvature, lens thickness and such, and hopefully this kind of metrics might potentially reveal hidden progression. And then we'll also be looking at demographic, ocular, as well as systemic conditions. And hopefully these variables are going to help us build a more complete picture of risk as well as potential outcomes. So for our analytical plan, we're planning on stratifying kids by presence or absence of systemic as well as ocular diseases and model longitudinal change using mixed effects regression. Subgroup analysis will also focus on kids with extreme baselines for spherical equivalent to see if their trajectories truly differ or not. All right, so for summary, early onset myopia, fairly rare, but has pretty notable clinical significance. These kids tend to be higher risk, understudied, and often under-referred. With better tools like biometric data, for example, and a more structured approach to monitoring and referrals, we might catch important diagnoses earlier and intervene in a more timely manner. These are my references. And before I wrap up, I really want to thank Dr. Huang, who's been a wonderful research mentor to me, whose guidance and encouragement has been incredibly essential to shaping this project. So I want to thank Dr. Stagg and Dr. Sari, among other collaborators in different institutions that have taken the time to review the study framework and offered really invaluable feedback. Thank you.
So I think the plan was to have Mubarik now. And he will talk about resident perceptions of intraoperative feedback in ophthalmology, a cross-sectional survey of quantity, quality, and educational impact. And we have an heroic fact about you. Yeah, Megan Johnson put it in there, but you would like me to say that, so obviously you saved her son in a flash flood?
Did you get much sleep last night? Well, we had a couple open gloves last night as well, but when it rains, it pours. Megan's being a little facetious, but we survived the flash flood together along with Dr. Simpson as well. Well, appreciate you guys being patient, and apologies for being late. Excited to present kind of this project that I've kind of been working on with the residents in regards to kind of resident perceptions on feedback surgically, intraoperatively here at the Moran Eye Center. So I'll just kind of go a little bit of as far as introduction, methodology, kind of results and analysis, some recommendations for improvement based on the survey results, some future directions, and then my references here. And so we know that with surgical subspecialties, it's a mentorship model with, let me see if I can grab this here, almost like an apprenticeship master relationship. And so feedback is vitally important to not only kind of gain skills in the surgical operating theater, but as well as just kind of make sure that you're progressing with the hope of being a independent surgical or surgeon at the end of your training. Several studies have shown that feedback accelerates surgical learning, which is not surprising. It's essential for autonomy development and clinical judgment, and strengthens technical and communication skills as well. Feedback is critical for expertise acquisition. Self-assessment is often inaccurate without feedback, something I've realized this year as well in regards to reviewing videos And then external benchmarks do refine surgical skills. And this is a kind of a learner graph here where you can see, you can identify outcomes, plan learning, and observe practice, feedback, and assessment as far as a feedback loop. It does have a impact on patient outcomes, which is also not surprising. Higher quality improves feedback, lower operative times, lower complication rates with adequate feedback has been shown. Particularly that study by DeRosa and Al was kind of a large study looking at not ophthalmology residents, but surgical residents in multiple subspecialties, and kind of graded feedback from the resident perspective and looked at complication rates and operative times. And pretty cool that those that felt like they had higher quality feedback had just better outcomes in general. And then does enhance team dynamics and communication as well. There are some barriers to effective feedback. Certainly we know that the time pressures, particularly in ASC, where the turnovers are pretty quick, can have an impact on just finding time between the attending and the resident. There's variable feedback among faculty as well, and then some of the hierarchical dynamics can hinder open feedback if there's not trust between the apprentice and the master. The study objective was to evaluate the frequency, specifically kind of the usefulness and specificity of feedback here at the Moran, identify any barriers to effective surgical feedback, and then propose actionable improvements. So this was an anonymous 17-item electronic survey sent to the residents. Participants were from PGY1 to PGY4, 12 total respondents, and focus areas were frequency, barriers to feedback, preferences, and then impact on surgical acumen and training. This is kind of what the survey looked like, and I'll go into the results here. And first question was, how often do you receive feedback after a surgical case? And most residents did receive feedback. About 83% had said they received feedback very often post-surgery. There's only one person that said they never received feedback, and overall demonstrates baseline positive feedback culture. And maybe, yeah, that was Jordan Desatel, who is always just doing perfect surgery. They asked how useful is the feedback that you receive from in regards to your surgical development, and overall 60% said the feedback was very useful, and in terms of progress, and then there was only one person that said it was slightly useful, and no one said it was not useful. In terms of preferred methods for use for feedback, we had asked residents which method do you find most useful. About 92% had mentioned verbal feedback immediately after surgery is useful. Some folks liked video reviews of cases, about 7%, and then scheduled discussion after clinic or at a later date was a minority. And then almost no one had mentioned written feedback or emails. In terms of barriers to receiving feedback, most often was, or cited, was time constraints after the surgery. 11 out of the 12 respondents indicated that. Only one person said attendings don't prioritize feedback. And then a couple people said, I don't feel comfortable asking for feedback. And 3 people said feedback is delayed. And then 3 people also said feedback is too vague or general. In terms of comfort level asking for feedback, majority of residents said they are comfortable. This indicate that it is a pretty open environment here, which is great. And feedback-seeking behavior is seen here, and which is a great thing. In terms of follow-up for feedback, majority said attendings only sometimes followed up in regards to their surgical cases. Only 3 people said very often is that they get feedback into prior cases, and then 1 person said rarely do they get follow-up on their feedback. In terms of perceived impact on surgical skills, majority, 60%, strongly agreed that feedback improved their skills. There's a clear link between feedback and skill acquisition, at least according to the residents. And then in terms of just overall open-ended questions, we had asked, how can faculty improve the quality and the impact of the surgical feedback? And almost everyone pretty much made a comment about seeking feedback right after a case or 2 or 3 cases during the day. Some of the representative quotes here, we'll go kind of from left to right. Following up with feedback during a case to make sure I'm implementing the feedback correctly. That was from a PGY2. Set a goal prior to the case on this case, I want you to focus on a certain step, then revisit that topic, was another comment. And then someone else said, would like to have a list of standardized feedback points as a general structure so that multiple points are considered. In terms of kind of the results of the survey, I think, overall there is a good culture in terms of residents being open and comfortable asking for points of improvement. Seems like majority of residents are also getting feedback during cases. It seems like the main barrier here is just protected time or lack of time in between the turnovers, which does make sense with just kind of how fast things move both here at the Moran and at PCH. And so certainly, you can think about protected feedback time after cases, finding a minute or two just to kind of sit down after each case, particularly for earlier trainees if they're working on multiple skills. This is with scale, which I was able to kind of find through looking at some previous models for resident feedback in terms of surgical training and then progression. And so at least for me, one of the biggest, anxiety-inducing things is just being able to know that I'm, competent to practice, in graduating residency in regards to surgical competency. And so this was developed by Dr. Schwitzberger, who was a thoracic surgeon in Kentucky, and then later modified by Dr. George in, I believe, Illinois, both surgical or surgeons. And so he had this 4-point method of just competency for resident surgeons that he developed. Goes from show and tell, active help to passive help to supervision only, and just a graded way of just providing autonomy and competency evaluation for his residents. And certainly that can be one thing we can kind of think about as far as specific skill, and both from the mentor standpoint and then for residents to feel like they are kind of meeting their milestones. And then we can do formal development workshops in regards to monitoring surgical progress and feedback. There's a lot of excitement in terms of the surgical curriculum as well with the Lyme Committee, and that's another area of improvement as well. In terms of conclusions, we do have a strong baseline feedback culture. Opportunities do exist to enhance the specificity and continuity of the surgical feedback, and obviously there's a potential for national leadership in surgical innovation in regards to education. Those are my references, and appreciate you, and thanks to everyone.
So Madison will talk about the comparison of IOL power calculation formula accuracy in post-radial keratotomy eyes. And Madison always had cats in her life, but she never got one by her own. They just found you.
Thank you. That is the truth. I've never gotten a cat on purpose, but I've never not had a cat, so they just find me somehow, and then they just stay, so that's fine. Okay, so if you think that this talk sounds similar to Sam's, you are correct, except we are doing radial keratotomy eyes instead of PK eyes, so thank you, Sam, for setting the groundwork for that. And so this is the roadmap of my talk. I'm going to start off with the history of incisional refractive surgery, go into the principles of radial keratotomy, and then go into the IOL power formulas, and then hopefully help us have more information on deciding which IOL power formula should be used for post-RK eyes. So I really like thinking about the history of surgery, because I think one of my favorite things is when we're counseling patients before any kind of surgery and their jaw kind of starts to drop. Even cataract surgery, anything that we think is so, we do it all the time, so we're not that impressed by it, but they're like, what are you talking about? So when I really start to think about any surgical procedure, I like to think about the history. So the cool thing about RK is that, it has a long surgical history, so back to the 19th century. So in 1885, I'm probably going to butcher all these names, I apologize, but Schatz from Norway was the first to treat astigmatism with incisions intentionally. And this was 4 months after cataract surgery. He used a limbal incision to decrease astigmatism from 19.5 diopters to 7 diopters. And even before this, I read some studies that the inspiration for him to to do this was from people that had corneal scarring, which makes a lot of sense. So people that had corneal scars, they started to notice that their astigmatism was different. So that was kind of the inspiration. And then Bates from America in 1894 developed a surgical technique for incisional astigmatic correction after observing patients with peripheral corneal scars. So kind of twofold here. So kind of inspired shots, and then also Bates, who had flattening of the meridian that crossed the scar. And then around that same time, so around turn of the century, 18 to 1900s, Faber from Denmark was the first to perform anterior transverse keratotomy to improve a patient's vision. So the other two were more astigmatism. This one was more for visual acuity. And then again, around the same time, Lucciola from Italy had 10 cases of non-perforating corneal incisions to flatten the steep meridian. And then Lanz, he is really the one who had the first, at least the first that I could find, doctoral thesis that described the systematic trials of non-perforating corneal incisions on rabbits to treat astigmatism. And then, as you can see, there's a pretty large jump from 1896 to 1978. The first RK surgery wasn't performed in the US until 1978. The US was kind of a late adopter of this surgical technique. And then this Dr. Boers began the PERC study, or the prospective evaluation of radial keratotomy study, in 1981, which examined the performance of 8 centrifugal incisions with the diameter of the optical zone determined by the spherical equivalent of the refractive error. And that was a large study. It had 411 eyes, and they followed them for 10 years. So that gave us a lot of information on kind of the principles of what we know about RK and kind of the longitudinal effects. So some principles of RK, these are actually from Lanz's research, again, way back in 1896. And so he was able to find out that deeper incisions exhibit a more significant impact. Non-perforating corneal incisions perpendicular to the limbus cause peripheral bulging and central flattening, which you can see in these photos A and B. And then keratotomy-associated wound healing induces further flattening of the central cornea. And lastly, radial wounds flatten the central cornea and create a peripheral inclination in the meridian parallel to the wounds. So kind of some more kind of modern principles of radial keratotomy. The effect of keratotomy increases with the greater depth, number, and length of the incisions. And so I'm sure that a lot of us on slit lamp exam have seen patients with RK, and there's a kind of large number of cuts that can like a range of cuts that can be present. 8 is the most common, but the range can be from 4 to 24 cuts. And the depth of the incisions is generally 80 to 90% corneal thickness. And the diameter of the optical zone, a smaller optical zone is going to have greater myopic correction. So one could think, why don't we just go smaller, 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 smaller? At some point, you're going to have more significant glare and halos. That's determined to be around less than a optical zone of 3 millimeters. And so past that, we kind of say the risk benefit is no longer good for the patient, because they'll have more glare and halos. And then interestingly, the PERC study's regression analysis documented an effect of 0.4 to 0.6 diopters higher per decade. So age is also something to consider. And interestingly, one more historical thing, and then I'll stop. There was a surgeon named Fyodorov, and he actually had really, really exceptional results. This was before America adopted RK as a surgical procedure, but he followed his patients for about 1.5 years, and he had 230 eyes. This was like a pretty convincing study, and he said, he got all of his patients within 0.5 diopters, which you'll see from my data that we can't do that today with RK plus cataract surgery, but a little different. But anyway, 0.5 diopters at that time, turn of the century, 1800s to 1900s, is incredible data. They're exceptional results. However, they've never been replicated. Multiple people have tried, so we don't know. So moving on to modern IOL power formulas. Again, this is similar to what Sam was discussing. So these are kind of the more modern, later generation formulas. And they all of these formulas have similar key variables, including axial length, AC depth, lens thickness, central corneal thickness, biological sex, and they all use keratometry values, except for the BTK-TK uses total keratometry. And then each formula uses different algorithms, and I kind of went into the weeds about this, but the general thing to say about it is most of these are incorporating artificial intelligence models. But they all have very different algorithms. All right, so as we all know, cataract surgery in post-RK eyes is a doozy, and that is why I'm discussing this today. But it's difficult to pick an IOL power with potential daily refractive fluctuation. That's kind of the first thing that I thought about is, we learn pretty early on in residency that RK kind of, causes the corneal edema that leads to corneal flattening at night and then resolves kind of throughout the day. And so some surgeons do measurements both in the morning and the evening to kind of think through this issue. And post-RK eyes tend to be more hyperopic in the morning. And then on top of this, another kind of complication of doing cataract surgery in post-RK eyes is the potential for hyperopic surprise. So the measurement in the 4 millimeter paracentral zone of the post-RK corneas overestimates the corneal power, which can cause hyperopic surprise. So suggestions to counteract this are things such as aiming for more of a myopic correction. If you're going to have a hyperopic surprise, you can aim more myopic and hopefully get a pretty good correction out of that. And then I did find kind of a cut-based kind of aid in choosing refractive error or refraction goal, I guess I should say, after cataract surgery. So for a 4-cut RK, some people add 0.5 to 1 diopter. For 8 cuts, you add 1 to 1.5. 12 cuts and beyond, you add at least 2 diopters. So it's pretty significant for the higher cuts for sure. And then lastly, of course, to counteract this, we could have the most optimized IOL power formula, which is what I'm hoping to talk about today. And then I did want to mention, of course, there are surgical difficulties. So these are kind of more the calculation difficulties, but I did want to just mention that, of course, there are also surgical difficulties, especially if people have a high number of cuts. There are different surgical techniques that need to be employed, such as a scleral tunnel, because, of course, if you incise where some of the RK cuts, that will complicate the surgery as well. All right, so this is kind of finally going into the research that I did with Dr. Savage. So which formula should be used for these patients? So we did a retrospective observational study on 21 post-RK eyes, and the average was 8.5 cuts, and that was from 13 patients, and they underwent uncomplicated cataract surgery. All of them had ZCBU IOLs implanted, and then the refraction data was collected a month after their surgery. And then, again, just like Sam's data, we did mean prediction error, mean absolute error, median average error, and then the proportion of the eyes within, quarter of a diopter, half a diopter, 0.75, 1 and 2 of the target. And then we did unpaired two-tailed t-testing. All right, so this is kind of the busiest slide. And I do just want to kind of point to a few different things. I have a couple arrows. So I know the colors are a little hard to see, but the BTK-TK formula is kind of that brownish color that I'm pointing to. And you can see I'm looking at the proportion of eyes that are within a quarter of a diopter. And the first thing you can probably see is that all of them are pretty low, all of the formulas. And the BTK-TK has the highest proportion, which is 0.32. Which is still not great. And then, as you can see here, we kind of went up to 2 diopters, plus or minus 2 diopters, and none of the formulas actually even got us reliably within 2 diopters. I mean, they were pretty close. There were a couple in the 0.8s, 0.9s, but still interesting to note that we can't even promise the plus or minus 2 diopters. So, like I said, this is kind of what I just said, but the BTK-TK resulted in the highest proportion of eyes within a quarter of a diopter. And this only achieves significance compared to 2 other formulas, the CK6 and the EVO formula with a P of less than 0.05. And none of the formulas were able to achieve all outcomes within 2 diopters. And then all formulas tended toward hyperopic outcomes with a wide variability, as seen in our positive mean predictive errors and large standard deviations. Our standard deviations are about 3 to 4 times the data that we looked at for just after cataract surgery without RK considered. So, as you can tell, it's hard for me to say, definitely use the BTK-TK formula. Our data is suggestive of that because the highest proportion of eyes were within, a quarter of a diopter there, but it's still only 0.32, and a larger sample size is definitely needed to confirm this finding. It remains very difficult to achieve accurate target refractions in post-RK eyes, even with modern IOL formulas that use AI. And cataract surgeons should anticipate a high refractive variability with a tendency towards hyperopia in post-RK eyes, even when using the 3rd and 4th generation formulas. So I'm sorry that I don't have the perfect formula for us yet, but anyway, thank you. I appreciate you. Oh, and here are my references, and of course I need to give a big thank you to Dr. Daniel Savage and Dr. Mark Mifflin.